At that time, we can band the braces of arch. So at that time, fixed appliances on the upper arch, posterior bite block on the lower arch. This is a banded RME with a hook. As you know, this is covered occlusal surface in the posterior area. The hook is placed between upper canine and upper first premolar area. Second appliance is a labiolingual arch with a hook. We'll bend on the upper first molar area, and this is lingual arch, and also added labial arch, and we'll added the hook this area. At that time, in the lower arch, we may choose posterior bite block or posterior bite block with the anterior coverage. Third type of appliance is two expansion appliance with the hook. It is similar to Hylex appliance. Compared to Hylex appliance, the only band on the upper first molar area. So this means is two bands. And also in the lower arch, we can choose posterior bite block or posterior bite block with anterior coverage. These are a face mask treatment to notice. Face mask therapy has both orthodontic and orthopedic effect. So we can achieve the skeletal change and dental change for overjet correction and molar correction. Usually in face mask therapy, skeletal change is greater than dental change. Second, face mask therapy needs to be earlier, maybe lesser than 8 years old. In severe class 3 cases, maxillary protection appliances can be used even after growth spurts of patients. But Dr. Bassetti reported that the forward movement of the point A, the control group is 1 millimeter per year. On the other hand, early treatment group around 6 years old age, the 4.1 millimeter per year. On the other hand, later treatment group around 12 years old and 2.1 millimeter per year. So the proper and best treatment timing for face mask is 6 to 8 years old. And also Wells and reported this. Positive overjet is maintained long-term in 70 to 75% of cases, whereas 25 or 30% of cases relapse. Because of increased horizontally directed and open rate mandibular growth, up to age 10, the time at which reversible headgear treatment began does not appear to be a major factor in long-term success in maintaining positive overjet. In some cases, we can see severe anterior crossbite. At that time, patient or parents do not want to reject surgery So at that time, we need non-surgical orthodontic treatment in permanent dentition. So it means we need fixed appliance and combined face mask therapy. Especially in class 3 deep bite, we can see the severe anterior crossbite and also prognostic chin. At that time, we need fixed appliance therapy with face mask. On the other hand, in class 3 open bite case, there is no need for face mask therapy. Third, in anterior crossbite with severe maxillary deficiency, a face mask should be used with the high penetrator expansion to maximize orthopedic effect. Fourth, anterior crossbite cases in which the mandibular anteriors already have adequate lingual tipping are good indications for face mask therapy. If the chin curve is too high position, what causes? So this is impinging on the lower incisor, and it may worsen linguoversion of the lower incisor. So this is good chin curve position. So this is a lip embrasure, and we need some 1 finger width. Fifth, face mask therapy for anterior crossbite exhibiting dental compensation, sometimes protruded maxillary incisors, must be accompanied with careful anchorage preparation to prevent creation of excessive maxillary incisor protrusion. Face mask therapy can cause the reversion of upper incisor. So linguoversion of upper incisor is the good indication, and also it is effective to face mask therapy. In some case, we can see the reversion of normal angulation of the upper incisor. Especially in reversion of the upper incisor, we can see the aesthetic problem. At that time, we have a special caution to use face mask, especially in class 3 open bite, and also high angle class 3 case, and also increase anterior vertical dimension and protrusive ribs and small low nasolabial angles. So it means later we need extraction treatment, even though this patient is class 3 patient. 6, if a face mask is used for treatment, use the new type face mask without the chin cap to prevent TM joint injuries. 7th, temporarily useful in carefully selected cases. Some cases we may choose face mask treatment or observation with the TPA and or resin overlay. 8, the long-term results are questionable, especially if there is a posterior discrepancy. So it means the patient has latent mandibular growth and the catch-up growth of the mandible. Treatment duration in general is around 6 to 9 months. If the crossbite could not be corrected during this period, continued wearing of the mask or substitution for TPA and or resin overlay should be considered. In this case, we'll be discuss the detail. These are common disadvantages of face mask therapy. The first, maxillary incisor protrusion may be created. Second, proper anterior overjet cannot be difficult, even though longer usage of a face mask. And third, relapse due to the late mandibular growth is not uncommon. Lastly, face masks with chin caps are dangerous for TM joint injuries. This patient is a 60 years old girl patient. She complained is anterior crossbite. This is a milk dentition not erupting the upper and lower first molar. Upper first molar position is higher. ODI 64, APDI 91, combination factor 155, class 3 high angle case. So this patient is skeletal class 3 malocclusion and upper incisors upon to FH 104. This is a lingual version of upper incisor. In lower incisor, 76. So this is a lingual version of lower incisor. This is primary dentition, and you can see the lingual version of upper and lower incisor. So we inserted the bonded RME with the hook on the upper arch and turn the screw once a day for 1 month. And next month, and they stop turning, and we use the face mask. So this is time schedule for bonded RME with hook. The first visit, bonded RME with hook and turn once a day. Second visit, no turn, and face mask delivery at that time force magnitude is 400 to 500 grams. At that time, the 5/16 of an inch of 6 ounces elastic. At that time, wearing time is more than 14 hours. Third visit, and then we can change the elastic, a quarter of an inch, 6 ounces of elastic. And we'll check the force magnitude. So at that time, there is a gap between embrasure and chin curve or forehead, this area. The parallel direction is the best. However, if the parallel elastic irritates the rib, we might replace the elastics diagonally, like this. And we can see that this. This is about 17 years old, 17 years ago patient. If I treat this patient and then I insert the resin overlay this area. However, fortunately, we can see this good settling. Okay, like this. During the growth, the patient, and then we can see the clockwise backward rotation of the mandible. APDI is 91, and APDI changed in 94. If this patient is there was no TPA or resin overlay. This is another case. You can see the anterior crossbite. So this patient is we insert the bonded RME with hook and turn the screw once a day for 1 month. This patient, you can see the already erupted upper first molar. So I did not cover this area. And after 1 month, I delivered the face mask, and we can achieve some good result like this. Nowadays, after eruption of the upper first molar, I do not use bonded RME on the upper arch. This patient is a 10 years old female patient. You can see the prognostic chin, this area. There is no crowding in the lower arch and also slight crowding in the upper arch. And also we can see the retained upper primary second molar. ODI 63, APDI 95, conversion factor 158, class 3 low angle case. This means is skeletal class 3 malocclusion. This patient is upon to FH 116. This means normal angulation of upper incisors. Lower to mandibular plane is 90 degrees. This is also normal angulation of lower incisor. This is the values, the measurement is almost normal. However, the patient has already erupted upper first molar. So this is upper labiolingual arch with the hook. The hook is located between canine and first premolar area. And also in the lower arch, we should use posterior bite block and face mask. So we can achieve some positive overjet like this. After removal of labiolingual arch, how can we observe the patient? So this patient, we can check the posterior discrepancy in the upper arch. During the face mask therapy, we can achieve some good result for the movement of the maxilla, point A. And even though the pogonion, the lower jaw can grow forward also. So this patient, as a retainer, we may use the TPA on the upper arch like this. And we can see nowadays, there there are erupting on the lower second molar area. Every 6 or 1 year, and then we may remove the TPA, upper TPA, and cleaning and re-cementation like this. And also we can see the posterior discrepancy in the upper disc, tooth number 7 and tooth number 8. After eruption of the upper second molar, and then we may remove the upper TPA. At that time, you can see the vertical height of the between upper and lower first molar area. The greater over eruption of the lower molar. On the other hand, less eruption of the upper first molar because of the inhibition of the TPA. This patient is 9 years old, male patient. You can see the anterior crossbite. There is no crowding in the lower arch. In the upper right canine, we can see some crowding, this area. In this patient is the upper labiolingual arch with hook, lower arch, posterior bite block, and face mask. So we can positive over jet and good profile. This patient is 8 years old, male patient. We can see the anterior crossbite and also anterior crowding, especially upper right maxillary lateral incisor area. This is posterior bite block in the lower arch, upper labiolingual arch. Due to the posterior bite block and the lower jaw can move backward. So it is good for class 3 treatment and added face mask therapy. So after jumping and then I cut the labial arch via this area. So some case we can use the labiolingual arch this area instead of TPA. And this patient in the lower arch, there is no space in the lower arch. On the other hand, we can see the severe anterior crowding, especially upper canine area. After eruption of the upper first premolar area, we can gain the space like this area. So at that time, if there is upper anterior crowding in class 3 patient, I'd like to wait upper first premolar eruption. When we gain the space, this means upper incisor may be proclined. This patient is 9 years old, a female patient. You can see the prognostic chin. Intraoral photos, we can see the severe linguoversion of the lower incisor. In the upper arch, you can see the severe crowding. ODI 63, APDI 94, combination factor 157. class 3 skeletal pattern. So this means this patient is skeletal class 3 malocclusion. Upper onto FH 106. This means lingual of the upper incisor. And also, low onto mandibular plane angle is 73. Severe lingual of the lower incisor. So low onto mandibular plane angle is the main problem, this patient. This patient is midline is okay and symmetry is okay. However, in the maxillary arch, and then we can see the downward position of the upper right area, this area. In order to treat narrow upper arch, how can we treat? We need expansion appliance. So some cases we need only maxillary expansion appliance. On the other hand, we need expansion in the lower arch and also added maxillary expansion. The both sides expansion is greater effect in expansion. And also we can choose this. In the lower arch, Schwartz appliance is an expansion appliance and posterior bite block in the lower arch. In the upper arch, there is no posterior bite block. This means maybe high-dex appliance or two expansion appliance. Especially in severe lingual tipping in the lower posterior teeth, this area, at that time, I want to use the Schwartz posterior bite block and two expansion arch wire with a hook like this. So as a result, we can gain the greater expansion of upper arch. So these are time schedule for using two expansion appliance with hook and posterior bite block in the lower arch. The first visit, full time wearing except eating and brushing. For two expansion appliance and then turn the screw once a day. And second visit is stop turning and face mask delivery and recommend the more than 14 hours wearing a day. The first magnitude is 400 grams. So this means is 5/16 inch of an inch, 6 ounces, or a quarter of an inch of 6 ounces. At that time, you should check the TPW, transpalatal width. And third visit, we may increase the force. And also, I want to check overjet and primary canine area. So some case, we need occlusal equilibrium on the upper and lower primary canines. And fourth visit, they continued wearing. Usually for me, the face mask is used to around 6 months. So this is a posterior bite block in the lower arch. The upper arch, two expansion with the hook. and turn the screw once a day. Right there. Change the labiolingual arch. Like this. We already discussed the upper anterior crowding is good for class 3 treatment. Okay. This patient is 8 years old girl's patient. Her mother has a severe class 3 and facial asymmetry. She complains anterior open bite. And also we can see this case. The canine area, canine relation is class 3. This means it may worsen during the growth. Okay, this patient, ODI 59, APDI 85, completion factor 145, class 3 high angle case. Compared to previous cases, this patient is class 3 high angle. This means the growth direction is like this. The patient maybe have the long anterior facial height, longer face. This patient is a skeletal class 3 malocclusion. Upper incisor is 116. This is normal angulation of upper incisor. Lower to mandibular plane angle is 90 degrees, is normal. So whole measurements are almost normal. However, you can see some class 3 primary canine relation. This patient, I insert Schwartz PBB in the lower arch and turn the screw once a week. In the upper arch, to expansion with the hook, turn the screw once a day. And once later, we use the face mask like this. After making good overjet, and then we insert the TPA. However, the loop direction, this forward direction of the loop is better. And we'll check the growth like this. You can see in the upper area, upper posterior area, we can see the posterior discrepancy. This is tooth number 6, tooth number 7, tooth number 8. Tooth number 7. This patient is 8 years old girl patient. You can see the anterior crossbite. There is no crowding in the lower arch. Also, there is no crowding in the upper arch. This is class 3 deep bite. And also we can see in the upper arch, there is the slight crowding in the upper arch. The midline is okay. The rim height symmetry is okay. On the other hand, the antagonal symmetry, the right side is too the downward location. ODI 65, APDI 92, combination factor 157, class 3. This means this patient is skeletal class 3 malocclusion. Fortunately, upper 1 to FH 104. This is Ringo version. On the other hand, it is not good. Low 1 to mandibular plane angle almost 83. This is Ringo version. And also we can see that there is a tendency over posterior crossbite. So this patient in the low arch, this is a Schwartz and posterior bite block. Turn the screw once a week. On the other hand, in the upper arch, this is two expansion with hook. And turn the screw once a day. And 1 month later, deliver the face mask. And this patient, we can see the great expansion of upper arch. How about the profile? We can see some protrusive upper lip. So, however, the occlusion is unstable. So, resin overlay on the primary first and second molar area, this area. And then we can see some edge-to-edge bite. During the face mask therapy, we can see some forward movement of the maxilla and downward movement of the mandible. And also we use the TPA on the upper arch. And we observe the growth and development of the patient. And then, at that time, I want to check the profile. It's not bad, okay. After exchanging of the buccal teeth, and then we'll check the profile and the assessment. There is no crowding. So I want to the lower second molar erupting the area. After eruption of the lower second molar, we'll start the fixed appliance therapy like this. This patient, and then band the braces upper and lower arch, and also this in the lower arch, this is mu 16 by 22 stainless steel arch wire. This is some kind of anterior vertical elastic, 3/16 of an inch, 6 ounces elastic, and finished. In Myo treatment, the treatment procedure is very, very simple. Leveling and we insert Myo. However, at that time, you should understand the mechanics of the Myo mechanism. This is post-treatment. This is pre-treatment before face mask therapy, and this is post-treatment. And we can see the forward movement of the maxilla and backward movement of the mandible. Like this. Especially in the upper first molar area. Compared to the lower molar area, and you can see the relative intrusion of the upper first molar. This patient, FPDI, is changed 92 60 into 86. Upper onto FH is 104 to 113, normal. Lower onto mandibular plane is 83, is changed into 84. This patient is face mask therapy is 4 months and observation 3 years, 8 months. At that time, we inserted resin overlay and TPA. And finally, due to the fixed appliance, we can achieve good result. The fixed appliance is the treatment duration is 30 months. So totally, the patient is 5 years, 1 month. However, the majority of these times is observation period. This is pre-treatment and post-treatment photo. You can see the good facial profile. For me, especially in class 3 malocclusion, class 3 skeletal malocclusion treatment, I want to use face mask. At that time, I only use 4 types of appliances. In the primary dentition, I want to use bonded RME with HU. After eruption of the upper first molar, if there is a posterior crossbite, I want to use posterior bite block in the lower arch and in the upper arch to expansion appliance with HU. If there is no posterior crossbite, this means there is no need to expand. So this time, in the lower arch, posterior bite block, in the upper arch, labial lingual arch with HU. This time, we already discussed these 3 types of appliances. The last appliance is in the permanent dentition, especially in severe malocclusion. I want to use fixed appliance braces in the upper arch, in the posterior bite block in the lower arch. After 10-minute coffee break, we'll discuss this. This is Jeju Island in Korea. This is Seongsan Ilchulbong. Come to Korea and enjoy this place together. Okay, 10-minute coffee break.
아까 질문이 뭐였어? 그럼 질문. I do close your door. 얘 이름이 뭐야? 아모아. 아모아.
Okay, we start. Let's move on to another topic. The last appliance is a fixed appliance and face mask. These two appliances, and we can achieve some non-surgical treatment of class 3 malocclusion. In class 3 malocclusion, I want to divide some two types: class 3 deep bite, class 3 open bite. In class 3 deep bite, we can see severe anterior crossbite and also difficult to brace on the upper arch. On the other hand, in class 3 open bite, it is okay to brace the brace upper and lower arch. For non-surgical class 3 treatment, face mask can be used as an adjunctive appliance for non-surgical class 3 treatment. Finally, we may use class 3 elastic force. This means upper dentition should be placed forward right there. So this means labial version of the upper incisor. It means unpleasing appearance. Some case, we may use face mask like this. Especially in class 3 deep bite treatment. The treatment strategy is first, increase anterior vertical dimension. Second, over eruption of the lower molars. Third, intrusion of upper molars. And also we should get arch coordination. The first method is somebody use the short class 3 elastic or mini screws. The other treatment plan, we may use posterior bite block with anterior coverage. The purpose is to increase anterior vertical dimension. This means is that we can achieve the backward movement of the lower jaw. And then we may use short crescent elastic. In severe crescent malocclusion, some case, posterior bite block with anterior coverage in the lower arch is the same. And we may use face mask and then short crescent elastic. However, at that time, you should remember this, the preparation for face mask therapy. This is first, one uniform maxillary dentition. Second, passing the center of resistance position if possible. And also, which one is better, root to labial movement or crown labial movement? For me, root to labial movement is better than crown labial movement. So this is center of resistance for maxillary dentition is maybe, this is upper second premolar and 8 millimeter distance, this area. So you can see the anterior crowding in the upper arch. Which one is better? So what is root to labial movement? So finally, we can see some crown labial movement, this area. On the other hand, also we can achieve the root to labial movement. On the other hand, some case, only achieving crown labial movement, what happened? The root, move the root to backward. So this means there is less space in this area. So in order to advance point A, so it is good for room made for canine. So root to labial movement is the better than crown labial movement. And also, it is possible in non-installation treatment and for aesthetic. At that time, we should check the bracket torque. As you know, in S/A bracket, especially in upper anterior area, the crown labial torque. On the other hand, the Kim's bracket is 0 degree torque in upper anterior area. What happens? In SWA bracket is greater crown labial movement and greater root to lingual movement. Which one is SWA or Kim's bracket? The treatment to result is almost the same. However, the crown, especially in the upper anterior position and angulation, is totally different. In picture A, what happened? The crown labial movement. This is SWA appliance. This is Kim's appliance. These are overall superimpositions between SWA and Kim's. there are changes in the upper and lower and also incisor and molar area, and especially in Kim's appliance, and we can achieve some bodily movement like this. This is a labial root toe. Labial root toe is dangerous tooth movement. What happened? This kind of tooth movement can cause the root resorption of this area or perforation of this cortical bone. Dr. Sutton already mentioned this labial root toe. This is a rectangular archwire and labial root toe like this. And this is circle rule. And this time, prior tie forward with the labial root toe to achieve arch length like this. So as a result, what happened? This archwire tend the upper incisor forward like this. However, it is not easy to apply in clinic to the patient. So for me, this is a labial root toe. And I want to use open coil springs, this area. This is red color, this means is crown lingual toe. Almost in general, 7 degrees crown lingual toe can cause crown to move the crown back and root to apex forward. At that time, what happened if we use the open coil spring this area? Move the crown forward and root to move the forward. In order to achieve this, and then so this is called strategic bonding. Do not bond to number canine and second premolar area. Some said the use labial root toe, the reverse direction in SWA appliance. This is the SWA appliance like this. The reverse direction, the upside down, this means the SWA appliance is maybe 12 degrees crown lingual toe. And then we may use open coil spring like this. What happened? This is a crown labial toe. And this is 0 degree toe. This is crown lingual, 12 degrees crown lingual toe. We can see this area and root to apex is contacting this cortical bone. It may cause root resorption or perforation. So Dr. Sutton, so the bracket is 0 degree, the archwire is crown lingual toe, and the meso tie back. However, it is not easy to apply with face mask. And also, this is reverse direction in SWA appliance, and the bracket is 12 degrees crown lingual toe. At that time, main archwire is 0 degree. It may cause a root perforation in case of no open coil spring and elastic. For me, I want to use the 0 degree toe and crown lingual torque in arch wire and open coil springs, and we can combine class 3 elastic and face mask. At that time, which one is better, full bonding or strategic bonding? Full bonding, it is simple. At that time, the both sides, the traction area is from upper first premolar area. In full bonding, so the LDR, so there is the bracket distance is short. So this means high LDR. So this means is heavy force can be applied. And also the timing for face mask is the later after leveling. The applied force is crown lingual torque. It may cause the root perforation. On the other hand, strategic bonding is do not bond upper canine and second premolar at the beginning of the treatment. So this means is longer inter-bracket distance. This means low LDR and right force. Especially if there is a crowding in the upper canine area, so it is easier and earlier to apply face mask. At that time, you should check the open coil springs and crown lingual torque. So the main arch wire is 16 is 22 stainless steel with crown lingual torque and open coil spring. The traction area is upper first premolar with Kobayashi arch wire like this. And also we want to have achieve over eruption of the lower molars in order to treat the class 3 malocclusion. If the patient has a primary second molar, we can use resin overlay on that teeth. However, in permanent dentition, we cannot use resin overlay. At that time, I want to use posterior bite block with anterior coverage. The main purpose is increase vertical dimension and this means and backward rotation of the mandible. However, what happened in this low molar area? Intrusion. So at first, I used the posterior bite block like this. This is a ball clasp, is placed on the between lower second molar and first molar area, second premolar and first molar area. And later, I want to cut the resin on the lower second molar area for eruption, this area. So nowadays, I want to change the design, the posterior bite block. So Adam's clasp is placed on the lower first premolar area, this area. So this is a typical pictures for posterior bite block with anterior coverage. Adult patient, class 3 deep bite, and we'll insert the posterior bite block, and then 1 month later, I want to cut this teeth, this resin area. And then we'll do strategic leveling and also finish with the mule. This patient is a 39 years old patient. So slight increase in vertical dimension. In Korea, Dr. Rate Young Kim said this. In Korean, 조금 means a little to movement in the upper incisor, lower incisor, upper molar, and lower molar area. So this patient is APDI 90, changed to 88. And upon to FH 107, this means linguoversion. And after treatment, 118, you can see the labial version of the incisor. However, it is not severe. The main problem in crest-free treatment, you can see the labial version of the upper incisor. Both face mask therapy and crest-free elastic, and the result is we can see labial version of the upper incisor. So I want to achieve this kind of tooth movement. In order to treat class 3, we should apply class 3 force factor. There are two kinds of force factor. One is elastic, the other factor is mini-screw. However, today I will introduce the elastic force shortly. Class 3 elastics are intermaxillary elastic placed on the maxilla posteriorly and on the mandible anteriorly. So long class 3 elastic, we can achieve the greater anterior posterior correction than short class 3 elastic. This is long span. However, these are potential problem in class 3 elastic treatment, especially in long class 3 elastic. What happened in upper molar area? Extrusion. Even though this patient is class 3 deep bite, extrusion of upper molar is good or bad. In Myo, the etiology factor of class 3 malocclusion is the over eruption of the first molar. So we do not want this kind of force. So in Myo, if you want to use elastic, we should use short class 3 elastic. This is Myo. This is the reverse direction of rotation force. Is in the upper arch, is located between upper first and second premolar area. On the other hand, in the Myo, in the lower Myo, and the reverse direction of rotation force is this between canine and first molar at this area. So every Myo has tip-back bend like this. So what happened? Incisor, you can see intrusion and labial version. Molar, intrusion and distal movement. Premolar area, extrusion. This is short class 3 elastic. Short class 3 elastic is upper part is placed on the upper premolar area. So maxillary dentition should be placed forward. Mandibular dentition should be placed backward. The point at the elastic wearing is the extrusion. So what happened? In upper incisor, we can see intrusion of labial version, upper molar, extrusion and major movement, upper molar, mesial movement. On the other hand, in the lower incisor, extrusion and linguoversion. So in myo, when you want to use myo in class 3, you should remember the torque. Torque upper myo is crown lingual torque. On the other, in the lower myo, crown labial torque. So this is a typical treatment procedure for class 3 non-extraction treatment. In class 3 deep bite, it is the same to apply this idea to the adolescent and adult patient. First, insert posterior bite block with anterior coverage in the low arch. If the patient is a growing patient, we may use the face mask and then short crest elastic. If adult patient, we do not use face mask and only insert posterior bite block with the anterior coverage in the low arch and short crest elastic. On the other hand, in the class 3 open bite, there is no need in using posterior bite PBBA. It directly bonding the brace upper and lower arch and leveling and myo and short and crest elastic and anterior vertical elastic. This patient is 11 years male patient. He had ENT problem and he had previous face mask therapy history and mandibular prognathism and familial history. There is no crowding in the lower arch. How about the upper arch? Upper canine area, there is no space. And also we can see there is a deep curve of P in the lower arch. We can see the enlarged palatal tonsil and midline shift to the right side and slight facial asymmetry. ODI 66, APDI 97, combination factor 163. This means class 3 low angle case. How about the profile? The patient has the prognathic chin, however, the profile is not bad. This patient is skeletal class 3 malocclusion. Upper incisors, you can see upper to FH value is 105 linguoversion. Lower to MP angle is 85. This is a linguoversion of lower incisor. Major perpendicular line is A point is placed to backward 8.4 millimeter. At that time, I used the posterior bite block. However, posterior bite block with anterior coverage is better because of there is deep curve of P. And this is a strategic bonding. Do not bond on erupted teeth area. So bond tooth number 1, 2, 4, 6. And using open coil spring in upper canine area. And this is main arch wire is 16 by 22 stainless steel arch wire, crown lingual torque. And this is open coil spring. At that time, maxillary protraction can be used on supplementary appliance to decrease anterior posterior discrepancy. At that time, the elastic traction from upper first premolar area. However, even though using face mask, it is not easy to gain proper overjet. I think this is because of the deep over eruption of the lower incisor. So that's the reason why I prefer PBBA in deep curvous P. So at that time, I added the resin under this area. And then, luckily, I see this remaining lower second premolar, lower second primary molar. So this is a resin cap, resin overlay, too high. And then I will wait. I'm waiting for eruption of remaining teeth. And then the left side, resin, this is lower left, the second primary molar was exfoliated. What happened? How about the midline? This patient midline slightly shift to the right side. This means I want to maintain these teeth. In Myo, the median deviation is from three factors. First, transverse problem. This means is narrow upper arch. Second factor is a vertical dimension difference between left and right side. Third, we emphasize the rotational discrepancy, especially in class 3 malocclusion. So this patient, I want to use this resin cap. And we are waiting for eruption of the remaining teeth. Okay. And finally, this resin cap was exfoliated. So at that time, there is no crowding in the lower arch, and there is slight crowding in the upper arch. 15 years ago, I used this wire banding. However, nowadays I want to use night tie arch wire. And then after leveling, we'll insert Myo. And midline shift to the right side, and this is short class 2 elastic from the upper first loop and lower third loop. Left side is short class 3 elastic from the upper second loop to the lower first loop and finish. And later, I want to extract these wisdom teeth. This patient, yes. FPDI 97 changed to 86. 81 is normal. On the other hand, the upper onto FH 105 changed to 121, slight labial version of upper incisor. On the other hand, lower onto mandibular plane 85 to 91 is normal. This patient is 8.2 lesion perpendicular line is minus 8.4 changes to minus 3.7. The normal value is 1 point. Almost 2 years later, we can see the good post-retention photos. This patient is 11 years male patient. You can see the anterior crossbite and anterior crowding in the upper arch. There is no crowding in the lower arch. How about the lower second primary molar? Already exfoliated. This is a second premolar. Yes. ODI 60, APDI 98, combination factor 158, class 3 low angle case. This patient is a skeletal class 3 malocclusion, upper onto FH 107, lingual version of upper incisor, and also low onto mandibular plane angle 81. This is lingual version of lower incisor. This patient is posterior located maxilla and lingual version of upper incisor and lingual version of lower incisor. The posterior bite block in the lower arch and strategic alignment. This means band the braces in the upper arch to number 1, 2, 4, 6. And then 16 by 22 stainless steel with crown lingual torque and open coil spring and face mask. So thanks to posterior bite block, it is easy to gain proper overjet. However, it is unstable. So this patient is face mask uses longer, almost 3 months, and we can achieve some greater overjet. And also, we are waiting for eruption of the lower second molar, this area. And after bonding, and we insert myo, and we want to check and midline match like this. This is short crest elastic. This is called vertical elastic. And finished. These are post-treatment photos. This. This patient is, the treatment duration is almost lesser than 2 years, 1 year, 8 months. APDI 89 and 98 to 83, class 1. Upper onto FH 107 to 118, normal. How about the low to mandibular plane angle, 81. This is a severe linguoversion. This is 86. In the low, this is, we should give the crown labial toe. No crown lingual toe in the low. These are superimposition between pre and post treatment. And these are post retention photos 3 years later. So during these 4 courses, and then we should remind this in crestally malocclusion, if there is a posterior crossbite, you can see the over eruption of the upper molar. This means the flattening occlusal plane and can cause the mandibular forward movement. So for crestally malocclusion, these are crestally etiologic factors, extrusion of upper molar. So treatment strategy in early orthodontic treatment, intrusion of upper molar. Second is increase anterior vertical dimension. However, in some case, in class 3 open bite case, we do not want to increase anterior vertical dimension. Third, over eruption of the lower molar. And also, we should achieve coordination over upper and lower arch. After treatment, at that time, you should check the retention. When you use this kind of wrap around the retainer or Holy type retainer. However, in crestally malocclusion, if there is a posterior crossbite in pre-treatment, at that time, I do not want to use this type removable retainer. This is TPA and lingual arch, and no labial arch for aesthetic. If there is a crowding in the upper canine area, at that time, intercanine bonding retainer or TPA lingual arch. If there is slight crowding and wrap around the retainer, this is tongue hole. And also, these are retention for low arch after crestally treatment. The general type retainer and severe crowding, and this is intercanine bonding retainer. However, in crestally malocclusion, the patient thrusts the tongue forward. So this is a spring retainer with the tongue creep. This is tongue creep in the low arch, this area. So this is my crestally differential diagnostic scheme. The first thing is single tooth crossbite. And second is check the profile at H to H bite. If the profile is okay or acceptable, at that time I want to check is it possible to make H to H bite? This means is dental or functional crestally malocclusion. So this time I want to differentiate these cases from maxillary dental problem or mandibular dental problem. especially in the low arch, there is a space. You should check this is mandibular dental problem. On the other hand, this is maxillary dental problem, and we can see the lingual version of upper incisor or crowding on the upper incisor. In some case, it is impossible to make edge to edge by. This is a skeletal problem. However, at that time, this case is a maxillary retrusion case. So at that time, I want to use face mask. If the patient the profile at edge to edge bite is not good, this means it's mandibular prognosis. At that time, I want to check the chin curve or observation or TPA. These are summary. First, if possible, it is better to treat cases of crest malocclusion early. For patients younger than 10 years old, it is recommended that orthopedic correct treatment not continue for more than 1 year. In general, I think 6 months is better. However, do not continue for more than 1 year. This kind of face mask therapy improves skeletal crest malocclusion by a combination of skeletal and dental changes. So 7 or 8 years old is the best treatment timing for crest malocclusion. Second, although early treatment may be most effective, face mask treatment can provide a viable option for older children as well. Face mask therapy can be used as a supplementary appliance even after growth spots in adolescents with severe crest malocclusion. Third, in a crest anterior crossbite with lower anterior space, we can achieve a favorable result through retraction of the lower incisor, along with the forward movement of the maxilla and or maxillary dentition. In this case, if there is no retraction of the lower incisor, what happened? We need greater labial and forward movement of the maxilla and maxillary incisors. First, after correction of anterior crossbite, we can check the growth and development of the mandible while inserting TPA on the upper arch and or resin overlay on the lower primary second molar, depending on the patient's occlusion. Fifth, and then phase 2 treatment can be started after the eruption of the lower second molar in cases where the prognosis is good. On the other hand, in cases of poor prognosis, phase treatment should be delayed until the end of the growth of the patient. In general, when female patients are 14 years old or male patients are 17 years old, we can decide whether to start orthodontic treatment or surgery combined orthodontic treatment. Lastly, during the observation period, you should monitor airway problems, tongue positions, upper second molar eruption. This can cause posterior discrepancy and lower third molar development while gathering data for the patient's growth and development. Many orthodontists know Myo is effective in class 3 and open bite treatment. However, it is based on the proper diagnosis. This means is the class 3 etiology factor is the first thing you should remember is over eruption of the upper incisor, upper molar, upper first molar. And adolescent or adult patient, the first class 3 treatment strategy is intrusion over upper first molar. At first, Myo concept is occur to you. However, if you know Myo and you will enjoy the Myo and orthodontic treatment. Thank you for your attention and bye-bye. And also, Dr. Amua asked me the question, the posterior bite block in the low arch, especially in the permanent dentition. So posterior bite block can cause the low jaw backward. So it is good for class 3 treatment. And nowadays, I already showed the design for modified posterior bite block. So in order to over erupt the lower second molar, and if you try this, and then you may enjoy and get the good result. Okay, bye-bye.